So actually I find that the development over the last years, moving from the concept of adaptive licensing, of which is, of course is still relevant, to talking about pathways, talking about adaptive pathways, etc., is really a good development. Because if we're going to get these things right, as we already heard from this Mark's introduction here, we need to have all the relevant stakeholders involved, and we need to really see things in the life cycle of the technologies or the drugs. So let me just say by start that the HTAs are often mentioned together with the payers, the decision makers, and that is all right, because we actually constantly work to identify how we can inform the decision makers. Sometimes the decision makers may be inside of the same organization, like, for example, in my own organization in Copenhagen. It may be in separate organizations, so the HTA organization is informing the decision maker, the payer. And we often say that we want to globalize evidence. We want to share evidence that we can share in order to reduce duplication of efforts. But at the same time, it's very important for us to localize the decision making. Where is actually the decision maker? That is at the national level, it may be at the regional level, to clarify the interaction between those who are doing this kind of value assessment by the HTA and the relation to the decision maker. In Germany, it's nearly defined by law how this is. Other places, it's much more deliberate, but it's important. It's important also when we talk about this, and Eunetha does indeed involve all the EU member states and Norway and Switzerland. It's important that we keep this in mind, that we're working with the member states, but we're actually working in a European process, and we're trying to find our way with that. So we come, many of us, from a research background, and actually that's also why we sort of, in the early 70s, introduced this concept of health technology assessment. I think today, perhaps we would call it value assessment of technologies rather than health technology assessment, which sounds like a little bit sort of distancing. Anyway, this timeline of innovation, so time is on the horizon and the use of the technology is on the vertical. That is a theoretical curve defined by a guy who actually more or less defined the concept of technology assessment and wrote a book, I think it was in 68. The key thing, as already also been alluded to, is that this is like a theoretical diffusion curve, but in fact it's very, it's possible to influence it. And for example, what we just heard about maps from Mark is actually an example of how you could influence this curve. Potentially, you could have another form of the curve where there might be a little, I guess it's called a little slope in the beginning, but then if there's really something here, it would be increasing immediately because you would have the system to adapt into actually seeing the benefits. But I also use this illustration to show where we work. I mean, the payers are particularly interested in us doing the rapid relative effectiveness assessment, which typically comes just after marketing approval has been given. And that's good, that's for good reason, but it has to be done rather fast, and it actually has to be done at a time when you have limited information. Particularly, you could say you have limited more information than actually the regulators have. So what we would like is actually that to work with the companies, that they would be more willing to share information with us from their studies directly, and also perhaps getting access from the EMA to data behind the regulatory process to be able to do this exercise of extrapolating or inferring best possible the real life effects, because that's what we are asked to come up with. How is it going to work in real life? That's something else than efficacy. And as we move along, we would be interested in more data to be collected in a quality way, so that we could make our estimates, our expectations of effect better and better. And that's where we see a number of overlaps also with what is going on in the area of vigilance and the expansion of the legislation about pharmacovigilance that we have in Europe now, which is also vigilance on real-life effect, you could say. And then to sum up, I think on this slide, I would say that we are used to work with the concept of life cycle. Actually, traditionally, the regulators have mainly been working sort of in a very specific time point, at least for the licensing. Then there is the issue of safety. And anything in this area can only move forward if there is a strong involvement of the HTAs in this process. I'm not saying the negative. I'm saying, again, we need to have a strong involvement of the HTA institutions and researchers in this process to make it work. The last one here is then going into, again, perhaps not so clear when this model was described by European projects in the 90s already. Maybe it was not so clear that we were talking about domains or aspects of value assessment. But as things are becoming clear, and actually as we are increasingly discussing with the stakeholders, including industry and patients, we actually get closer to understand that what we actually are doing is assessing value as best possible, or estimating value. So for the upper of these domains of the HTA core model that we developed, we would go as far as we're able to do with clinical effectiveness. Again, this is talking about effectiveness, so we're doing our best using the trials data available from the regulatory side, but any kind of epidemiological data will be applied. Again, talking about the maps, it's not like it's a new thing for the HTAs to use non-randomized information. We're used to have sort of this approach that you use the best available evidence, and then you assess the quality of that evidence, but you don't just automatically exclude evidence that is non-randomized. Again, the payers are, I would say, regrettably, mainly asking for these rapid assessments. I think they should actually be asking more for the full HTAs, the comprehensive HTAs, that actually address also the aspects of the systems consequence of the new technology. What would be the change of the patient pathway when we introduce this new drug? What kind of additional diagnostics would we need, etc.? Would the patient actually be able to be discharged earlier to be in primary care and at home rather than in hospital, etc., etc.? And so in order to go about come to the issue of data, better data, I think that it's important for us to find out with the IMI-2 how far is the IMI-2 able to actually go into involving other kind of research traditions than those that we always meet, which is the science tradition, the medical tradition, including more research areas of organization of care, analysis of organization, analysis of societal impacts and patient aspects. If it's possible with Horizon 2020, the EU program, and with the IMI-2 to go in this direction, I'm sure that we would have a number of ideas of studies that could expand the evidence base for those things that are in these domains beyond the traditional clinical domains. Again, organization, patient aspects as the key aspects. And if you're not tired of conferences, consider going to Rome by end of next week, because we have about 450 30 to 50 people participating in a conference where we're going to discuss HTA 2.0. And what we mean with this is actually what is going on here, hopefully, that we are getting out of the silos and getting much more into networking and discussing how we can find the way forward to actually have effective treatments to the patient as soon as possible. Thank you.